graft versus host disease. We're going to start with Professor Guillermo Ruiz-Argüelles from the Centro de Hematología y Medicina Interna de Puebla, Mexico. He's going to talk us about conducting hematopoietic stem cell transplantation in low and middle income countries. I have to say that it is my pleasure to be here to present Guillermo. Guillermo is a very good friend, a master of a lot of hematologists, and we follow his example for many years on how to do a good job, a good, cheaper job, accessible to everybody. So, please.
Guillermo. Thank you very much, Jose Maria. It is indeed a pleasure to be with you here and to address this point, which has been very interesting for us for very many years. So, I do not have conflicts of interest. I am going to speak about conducting HSCT in low and middle income countries. Those are the low and middle income countries in the world. 82% of the inhabitants of this world live in low and middle income countries. So, the methods, the change of methods that I will address refer to people living in these places. This is a picture of the world during the night. Obviously, this is a composed picture, but the places where there is more light are those that have more money. And if you keep in mind this image and you compare with the distribution of the centers participating in CIBMTR, you can see that the distribution is about the same. That means that CIBMTR centers are located where there is money. And we feel that this is not strictly fair because a lot of places in the world do not have money, and they also deserve the stem cell transplantation programs. We have calculated that in Mexico, we are grafting only 5% of persons needing an HSCT. And where the rest 95% of persons who do not have an HSCT, they are not with us, unfortunately. In 1982, I spent some time at the Mayo Clinic, and I had a chance to meet there Professor Clark Hoagland. He was by then the chief of the Department of Bone Marrow Transplantation in the Mayo Clinic. And when I came back to my city, Puebla, in Mexico, in 1983, I decided to start a bone marrow transplantation program. And I decided not to reproduce the experiences that I had seen at Mayo, but instead develop our own programs and obviously identify and break dogmata. And it was critical to engage in teamwork. Since 1993 to September 2022, we have done in our clinic 1,713 stem cell transplants. Autologous transplantation represent 1,466. So we have been able to start a bone marrow transplantation program in Mexico. The main indication for allogeneic transplant is, in our experience, is acute leukemia, whereas the main indication for autologous transplant is multiple sclerosis. We have grafted by now 1,317 persons with multiple sclerosis, coming from different parts of the world. Some time ago, I was invited to write this opinion about the lessons which I have learned starting a bone marrow transplantation program in resource-constrained settings. And some of the arguments that I discussed in this particular publication, I will present to you. This was recently published in Lancet Hematology. Very recently, there was a thematic series on hematology published in this journal, Hematology, in which I also addressed the item of conducting hematopoietic stem cell transplantation in low and middle income countries. This is a very recent publication. So these are my recommendations. Number one, Start with autologous transplants in patients with hematological malignancies, specifically multiple myeloma. Then do not freeze the cells. Do the transplantations on an outpatient basis. Next, consider patients with autoimmune diseases which are eligible for autologous transplants. Then introduce outpatient allogeneic transplant, initially using reduced intensity conditioning. You don't need HEPA filter rooms. You don't need laminar flow cabins. Do not graft cord blood cells. Do not start cord blood bank. Haploidentical transplantations are more feasible and more cost-effective and equally effective. Use generic drugs and biosimilars, and do not buy blood product irradiation devices. So my recommendation is starting with autologous transplants, autologous HSCT. Multiple myeloma is the easiest one to start with. You can also use it in lymphoma, employing non-frozen cells. You don't need a cell freezing unit. Do not buy a cell freezing device. Use short preparative schedules such as high-dose melphalan, which is useful both in lymphoma and myeloma, and do the transplants on an outpatient basis. This is our procedure. Usually we use only high-dose melphalan for both lymphomas, Hodgkin's and non-Hodgkin's, and also myelomas. And we have shown that they work about the same, both for patients with lymphomas and patients with myeloma. We have proved that freezing the graft is not necessary for auto transplant for plasma cell myelomas and lymphoma. And this is a multi-Latin American experience recently published. We honestly feel, Bob Gale and myself, that the big freeze may be over. You don't need to freeze the cells anymore. The transplant for multiple myeloma is also very simple in our hands, and this is the first one that I recommend to start with in a bone marrow transplantation program. We have recently shown that high-dose melphalan is an adequate preparative regimen for autologous hematopoietic stem cell transplantation in lymphoma, both Hodgkin's and non-Hodgkin's. See, you can see the overall survival of patients transplanted with high-dose melphalan versus beam-based schedules. They do the same. And the cost of melphalan in some countries is relatively cheap. In Spain, is probably the place in all the world in which melphalan is very affordable. So the next step should be to proceed with HSCT in autoimmunity. The best disease to start with is multiple sclerosis. You can also do it in CIDP, systemic lupus, Crohn's disease, and rheumatoid arthritis. So up to now, we have grafted 1,300 persons with multiple sclerosis. This is our preparative regimen, the Mexican way to transplant HSCT, to make HSCT in patients with multiple sclerosis. We use 4 doses of cyclophosphamide, 50 milligrams per kilo in each one, making up a total of 200 milligrams per kilo. And then at the end of the transplant, we deliver 1,000 milligrams of rituximab. This is the place of the world of the patients that we have transplanted in our clinic. Most of them come from the United States, but there are also persons from the United Kingdom, Australia, Canada, Norway, and so on. We have shown that in our hands, the EDSS score improves after the transplant in primary progressive multiple sclerosis, secondary progressive multiple sclerosis, and also relapsing remitting multiple sclerosis. We have published that this is possible. This is a feasibility study. We have also published that this is a safe procedure, 426 persons in this publication. And we have also shown that it works. The self-reported changes in the expanded disability status scale improves in persons with multiple sclerosis. This publication was done with 617 patients. And very recently, we published our experience with the transplant number 1,000 for persons with multiple sclerosis in Mexico. The results of our method are similar to the ones reported by Professor Bort and some other investigators all over the world, and are clearly superior to the results obtained with any one of the novel drugs employed in the treatment of multiple sclerosis. So we feel that the best treatment for multiple sclerosis is nowadays hematopoietic stem cell transplantation. Our method has a diminished kidney toxicity and a diminished cardiac toxicity. We have shown that the glomerular filtration rate by splitting the doses of cyclophosphamide in 2 blocks is decreased, as well as the cardiac toxicity. We analyzed the cardiac toxicity in this group of 1,000 persons with multiple sclerosis grafted. How are the numbers of persons with multiple sclerosis transplanted all over the world? Well, in this recent publication concerning autologous hematopoietic stem cell transplantation in multiple sclerosis, this paper refers to 4,831 persons, and it's interesting to show that the largest number of patients included in this paper is our experience from Mexico. Dr. Burt in Chicago has transplanted a smaller number of patients, also in Germany, and Professor Muraro in Italy. So by now, it seems that we have now the largest experience. These results in persons with multiple sclerosis show that event-free survival, MRI activity, overall survival, progression-free survival, relapse-free survival, and NIDA, no evidence of disease activity, improves in around 80% of persons with multiple sclerosis. These results are clearly superior to those obtained with the novel drugs. So the next step is to start allogeneic hematopoietic stem cell transplantations. Do not build a BMT unit. You do not need one. HEPA filtered rooms are not necessary. Laminar flow rooms are not necessary. Devote funds to laboratory and drugs support. Do the transplants on an outpatient basis and employ initially reduced intensity conditioning. This is the first paper that we published using the Mexican method to conduct allografts without a hospital, done on an outpatient basis. Those are patients from Monterrey by Professor Gomez Almaguero from our group in Puebla. This was published in year 2000. And this is our method. We employ busulfan, cyclophosphamide, fludarabine, and then methotrexate and cyclosporin A. All these drugs are given on an outpatient basis. We recently did this review about allogeneic hematopoietic stem cell transplantation conducted as outpatients. And in our experience, the largest number of persons grafted with this method is mainly acute leukemia. The next recommendation is to stay away from machedon-related donors or cords. If you need alternative donors, you have to learn that domestic cords, at least in our countries, do not work nicely, are suboptimal. Imported cords are extremely expensive. We suggest not to start a cord blood bank because you will end up with a lot of cords and you don't know what to do with them. Machedon-related donors are extremely expensive. Be the match helps somehow, but it still is very expensive. And haplos are the solution. Employ reduced intensity conditioning in haplos and employ peripheral blood in haplos. Do them on an outpatient basis. This is data of our experience in Mexico of haplos versus cords. Haplos are cheaper, employing post-transplant cyclophosphamide. cord blood banks are decaying, and haplos are more realistic in underprivileged circumstances. We do the haplos on an outpatient basis, employing reduced intensity conditioning. So there are two ways to make haplos. One of them is the Clinimax, and the other one is post-transplant cyclophosphamide. Clinimax is very expensive, and it's not realistic in underprivileged circumstances. This is the conditioning regimen that we use for outpatient-based haplo-HSCT. We use cyclophosphamide, 2 days of cyclophosphamide post-transplant, days +3 and +4. And this is interesting. What's the amount of cyclophosphamide that you need to make a haplo? Well, usually it is 50 milligrams per kilo, but there is interesting data about lower doses being employed. We are using 25 milligrams, half the doses, on day 3 and 4, and we have shown that they work the same efficacy and they are less toxic. So if you decide to do transplant on an outpatient basis, cut down to 50% of the dose of post-transplant cyclophosphamide. This paper that was presented in ASH recently refers to 50 milligrams versus 25 milligrams and the prevalence of acute graft versus host disease. This is also another proof that you don't need big doses of cyclophosphamide to prevent the graft versus host disease. We can do this in children, and we have shown that the results are the same as cords. This is Mexican experience. And obviously, haploidentical transplant is substantially more cheap than cords, more easy to do. We have Dr. Gomez Almaguer published this experience with haplos outpatients using reduced intensity conditioning, 60 persons. And then we also published 20 more patients proving that haplos indeed can be completed fully on an outpatient basis. Another recommendation is employ generics and biosimilars. Generic filgrastim works in Mexico as good as the original filgrastim. We have shown this both in Monterrey and Puebla. And also 50% of the dose of plerixafor is enough to mobilize persons when they are going to receive autologous bone marrow transplantation. You don't need to irradiate the blood products. The white blood cell filters are enough. You don't need this machine, which is costly. And this is a paper published by the group of David Gomez Almaguer, in which he analyzed the prevalence of graft versus host disease in persons who were given either irradiated or non-irradiated blood products, and it's the same. So you don't need to give radiation therapy to the cells transplanted to persons after the transplant. We have also been interested in publishing our experience. This was our first paper concerning transplants in 1993, and this is our last publication in 2022, and we have done since then 167 papers. So we feel that it is very important for us to to show the scientific world our results so they can reproduce it. Our suggestions are start with autos, specifically with myeloma. Do not build a BMT unit. Conduct SHCC as outpatients. Move into autoimmune conditions. Employ non-frozen cells. Do not buy a cell freezer. You don't need it to start a bone marrow transplantation program. Then, once you have gained expertise in autos, move into allos, employing reduced intensity conditioning. Do not start a cord blood bank. Do not use cord blood cells. Stay away from Macedon-related donors. They are extremely expensive if brought from abroad. And then move into aplos, employing post-transplant cyclophosphamide, probably employing the 50% dose. Do not buy the Clinimax, which is extremely expensive. Employ domestic biosimilars. Avoid the irradiation of blood products. Do not buy an irradiation machine. And if you don't know what to do, ask your wife. This has proven to be very effective for me. This is my wife. And she has taught me all the things that I know about stem cell transplantation. So, the Mexican HSCT methods cure about the same proportion of patients, are not simple ways to allograft. They do need a strong laboratory support. They do not require special BMT units, can be conducted on an outpatient basis, and are substantially cheaper. So this has led, in our experience, to be able to graft more patients, be able to cure more patients. Some of the patients that we transplant get cured, not all of them, unfortunately. We have been also interested in publishing papers, and we feel that we have somehow improved the education of physicians in our country, and also the healthcare system. So this is the final slide of my lecture. This is my family, my son, 3 sons, my wife, 7 grandchildren. 4 of them are ladies and 3 of them are males. So all of them have supported me to go around making some research and delivering lectures like this one. And I am very grateful to all of them. Again, I would like to thank the organizers of this meeting for their invitation to share with you these concepts. And this is my electronic address. If anybody needs more information, I will be glad to help them. Thank you very much.
Thank you very much, Dr. Ruiz-Argüelles, for this